Most nurses do not understand the rules and regulations that dictate our professional license. And that is truly because when we're in nursing school, what do we need to know for the test? Like, I'm never going to break the law. And so what do I need to know? Because I'm drowning in medical terminology. I'm drowning in care plans. I'm drowning in how am I going to pass the NCLEX? The last thing that you're worried about is, am I going to break the law? So I tell nurses it is a tool to start to educate you, but it's not the end resource. But I do think that all nurses should introduce themselves to some jurisprudence.
Hey, future CRNA, welcome to the CSBA podcast. CSBA has helped over 3,000 nurses like you gain acceptance into schools across the country. Tune in for inspiration and actionable takeaways to help you from start to finish. Hello, future CRNA. Welcome back to CSBA podcast. You do not want to miss today's episode. It is going to be given to you in part 1 and part 2, and it's going to be what are some proactive measures you can take and implement in your current practice as an SRNA and CRNA that would shield you from legal liability. We have expert Maggie Ortiz, who's going to share with you her insider knowledge on being a paralegal nurse. She's actually in the process of getting her legal degree. She is the bomb diggity, but it's going to be a part 1 and part 2 because we had so much fun with this. And I shared real life experiences that I have had as a CRNA. I shared experiences that I have heard from other CRNAs sharing legality issues that they have come up with in practice. And she shares a lot of knowledge and wisdom on what proactive measures you can take to protect yourself, as well as what do you do if something were to arise. So make sure you save this podcast, follow it for part 1 and part 2, and let's go ahead and get into the show.
Hello, everyone. Welcome back to CSB Podcast. I'm so excited to have a special guest today. This is Maggie Ortiz, who is the founder of Advocates for Nurses. And she is here to share what proactive measures can a NAR and a CRNA implement to shield themselves from legal liability. This is such a unique topic that we've never had on the show, and it is so incredibly valuable and something that you really need to make sure you put your earbuds in and listen to this show from start to finish. So welcome, Maggie. So excited to have you here.
Thank you. Love to be here.
Yes. So I would love for you to start out by just sharing, actually, I would love to give a little backstory because why not? So me and Maggie met. You're probably wondering how in the heck did we connect? But we actually met at a health tech conference called Vive, which was out in LA. Really unfortunate what's happening out there right now. But that being said, it was wonderful to connect with her there and with other nurse entrepreneurs who are really out there just leading the way and trying to address some major pain points within our profession as a whole. And it was really clear to me, you guys, when I met Maggie, that she just was so incredibly passionate about helping nurses defend themselves and protect their license and to practice smarter, not harder, to essentially be in the know so they can, avoid some really costly mistakes and potentially even mistakes that could, ruin your career. So it was really clear to me that, she's a wealth of knowledge, and I would love for you to share, how you got into this and where you are today with, I know you're going back, getting further in your education and legal, and just kind of share with our audience how all that became to be.
Such an honor meeting Jenny. I love everything that she's doing. And like she said, met at the health conference and been a nurse for 25 years, actually this year. Started with my associate's degree, started in the ICU, ER, pre-op, PACU, endo, IR, cath lab, structural heart. So all of my stuff primarily was in the hospital setting. After about roughly 15 years of practicing, I left a freestanding emergency room and I made my first crossover to legal nursing. I became an investigator for a board of nursing. So I had to go to national training to become very intimate with the rules and regulations and how to apply those if a nurse, any nurse, and it doesn't matter if you were an LPN or a CRNA, it does fall to the investigator to start that process of that case. So when I was there, I noticed some things that were happening, what, we know as our constitutional right of due process. And then that is why I created Advocates for Nurses. I started advocating, studying up on administrative law and what can a nurse do to protect themselves. Like I said, it doesn't matter if you're an LPN or a CRNA, you're calling yourself a nurse. So what does that mean? All those rules and regulations are applicable to you. They're not specific to necessarily your level of education. So if you're using the word nurse, you better know what that means. So I just have dedicated my life to studying. I am pursuing law school now because I do want to make real change for us. Most nurses do not understand the rules and regulations that dictate our professional license. And that is truly because when we're in nursing school, we just want to know what do we need to know for the test? Like, I'm never going to break the law. And so what do I need to know? Because I'm drowning in medical terminology. I'm drowning in care plans. I'm drowning in how am I going to pass the NCLEX? The last thing that you're worried about is, am I going to break the law? And then just to make this just one more longer before we move on, Texas and New Mexico jurisprudence, the course jurisprudence is required for endorsement for every doctor, nurse, PT, OT, to be endorsed or hold a professional license in the state of Texas. We have to take the 6-hour CE course. And unless you hold a license here, you cannot take it. But there are other entities who do have another course that's similar to it. And it's basically the intersection of your license and the law. And then we have to take it every third cycle, the 3-hour CE, but it is written in graduate level. So I tell nurses it is a tool to start to educate you, but it's not the end resource. But I do think that all nurses should introduce themselves to some jurisprudence.
Yes. And I am familiar with that CE, that mandatory CE that comes up every now and then. And I'm going to be perfectly honest. I'm sure I'm not alone, because I often don't pay much attention to it. And I think, like Maggie mentioned, we go into this profession not thinking, okay, I'm going to go in here and break the law. Most of us don't even worry about that because we're like, of course we're going to follow the rules and like, we're going to do what's right. And so it's not on the forefront of our mind that this is even should be a worry, but it really should be, mostly because there's situations that come up that really can be out of your control. And I will share a story that I had shared with me when I was actually in training, in anesthesia training, and it stuck with me still to this day. I was working with a newer CRNA. She had only been practicing for maybe about a year. We were doing a big case, a big bloodletting case. And so she made sure to tell me what had happened to her not too long prior. And this was at a major academic facility. I'm not going to mention any names and to keep things private. But long story short, what happened was during a messy case, the patient was bleeding out. And so they were using Cell Saver, which is for those of you not familiar, you take blood off the field, you filter it, and then it's given usually back to the anesthesia to give back to the patient, to try to salvage some good blood for the patient versus having to receive blood. So that was done. And at this facility, they had these really old school pressure infusion things that literally you put into this like device and you flip a switch and it goes poof, and it just pushes the entire flu bag.
Level 1. It's a level 1. It's a level 1 infuser.
There you go. Well, unfortunately, that bag was not de-aired, meaning that bag still had a lot of air in it. So this ended up causing patient harm. A lot of air got infused and it fell back on the CRNA. So it gives me goosebumps because, how life-changing, how altering to know that you played a part in someone's, ultimately bad outcome. This patient had a massive stroke, never end up being the same, right? And so they were brought into this legal case. Their chart was scrutinized to the fullest. And she shared a lot of information with me that stuck with me because it was very terrifying to even hear her. And you could tell she was still rattled. This was like months and months and months later, but she was very adamant that she had to share her story because she wanted to protect, other potential CRNAs from making this devastating mistake. And that whole facility no longer used that. Those became not usable, meaning they got rid of that equipment completely. But, I did open heart for a long time. And, the perfusionist would hand me those bags of blood and they were usually de-aired. Well, every now and then they were not. And so I got very prudent about double checking that. And it was because of the story she shared with me that's why I was very prudent. And yeah, I guess, what are some things, common legal issues that you see affecting, in the realm of anesthesia? I would love to hear some insights that you have seen.
And so just so we're putting it all on the table, I'm just a nurse. I'm not a lawyer. I never give legal advice. This is never legal advice. You got to get your own lawyer. But just to swing back to some of the things that you said, you're touching on several different things. You're not only just talking about the act of an error, but you're also talking about something you'll never put down. That you already told me she didn't put it down, right? And I speak about that. I interviewed Redonda. Most people know like her case, right? And the one thing that profoundly, she's the Vanderbilt nurse who gave a paralytic and not Versed, which we're not going to that because there's so many mitigating circumstances to that were not brought out. But you know what? I remember the things that she was saying is the first thing that she walks in the room because she says what she does, but it's the nurse practitioner who says, I'm sorry, because she knows the weight that Redonda is going to carry for life. to your point and what you said, right? You're going to get through, you're going to pay your restitution, you're going to pay your fines, you're going to get through all this stuff, but you know what you're never going to put down? That. So I think that that's profound as well. I'm more than happy. And we're going to talk about legal stuff, but that's the other reason why you have to protect yourself, because that is what leads to burnout. That is what leads to some of these other stuff. So what it came down to is what she did or did not document. It will come down to, because what is it going to be? It'll be a nurse anesthetist with the same or similar circumstance who will be giving their expert opinion. The nurse anesthetist will be writing up a report and can be deposed on that and will be asked. And the nurse expert is just unbiased, because that could be you, that could be anyone. And they're just an expert giving their unbiased opinion on a case that's been presented to them. So it's always going to come down to what you did or did not document. They will subpoena the policy, who taught you, what was their training, was this culture, how was this misstep? They'll be looking at some mitigating circumstances. So to your point, what you do or do not document is huge. And the biggest litigation that nurse anesthetists are involved in are diversion. Oftentimes that is one of because RNs and CRNAs have and anesthesia. So if you look at the highest incident of people who divert a drug, it is the people who have the most access to it. Well, who is that? So it's a logical argument. You can see that, right? So anesthesia, CRNAs, RNs. So we all have the most access to these drugs. So let's just swing over to like the border nursing. If my own state, 30% of the cases that are disciplined in Texas, which is roughly a total of 1,400, are punished. 30% of the 1,400 annually, and I can't do that quick math, I apologize, are related to diversion, but that also could be drinking and driving. It could be a public intoxication, but more often than not for the nurse anesthetist, it is the diversion of the drug away from the patient. And that's all that word means. And it doesn't even have to be a controlled substance. People make this misconception that diversion of anything is a controlled substance. It's not. It could be labetalol. You took the labetalol home and you used it on your cat or whatever it is. The literal definition of diversion is on my podcast in December. I had a healthcare attorney on, and he said it was a nurse who diverted an antibiotic, gave it to her mother-in-law who died. Or I can't remember, or it was her family member who had a bad outcome. That's still a diversion of a drug because it was just the mere removal of the drug, but it doesn't have to be a controlled substance. Swinging back to all that, most of the complaints in my experience have been around, for nurse anesthetists, the diverting of the drug, giving the drug. So paralytic, I don't know if you saw the case, similar to Redonda's, the SRNA gives a paralytic instead of the Versed. So pulls it out. I know how you guys like to label your drugs. And my understanding of the case is that someone went back to the OR because they were doing something in pre-op and asked the nurse anesthetist signed to the case, hey, did you pull your drugs or whatever? We're out in pre-op. We're going to do, I don't know what it was. They were going to do a block or something and said, you had your drug. So they handed off. So I believe they went to the pre-op. So how many times did this drug change hands before someone gave it? But you see where that's culture and not what we're supposed to be doing. And even in the cath lab, I had a pharmacist, I was on her podcast, because you know what anesthesia does? They will hand over the whole Pyxis and the Omnicell, where the nurses won't do that. You cannot hand over a drug and not have some kind of sign off, where your people are way better about it and the RNs and below are not. But swinging back to, it's normally around the misappropriation of drugs, not monitoring. So unfortunately, we've seen some nurse anesthetists on their phones during cases. And how can that be noted? Oh, that's your phone. If you choose to be on your phone, that's discoverable evidence now. So now you'll be handing over that phone, and that's going to be handed over. So I got really long-winded, but you got to document. You have to document everything. And I don't know your specific modality, but I do believe that in most instances, there has to be an anesthesia provider there. I think Texas, the MD can have 5 CRNAs or a combination of AAs and CRNAs. But so you have to be communicating with your doctor. If you have any problems, any questions, and you're calling the doctor, because the AA, and you guys know what this is, right? The anesthesia assistant, this is utilized a lot in Texas. For those who don't know what that is, I'll let Jenny explain it, right? They have normally their undergraduate doesn't even have to be in anything medical. And then they go and they get, will you explain that? Because I don't want to speak inappropriate.
It does tend to be of some type of science background, but you're right. It can really be in anything. But oftentimes they have to still have certain science prereqs to apply, but they could be an arts major and take some sciences and get in, meaning they don't have to have a bachelor's in science, but they do have to meet certain course requirements to be considered for the program. And it is really just anybody who can apply to that program who takes those courses.
And they don't have a license. So in Texas, the AAs try to position the board of nursing to ask for a license. And I know, like, one of the people, I was like, why would you do that? That's a gift. You are literally an extension of the MD. You're getting paid the same amount as an RN and you don't incur the same liability. Like, what? This is a win-win for you, right? So I don't understand. So my point being is, you as the CRNA are licensed. You do not work under the doctor's license. You are not an extension of the doctor. You have to uphold the standard of care. If you get called in front of the board of nursing, they ain't calling the doctor. They are not calling the doctor. You will stand alone in front of the board of nursing if you deviate from the standard of care. If you did not rope in the anesthesiologist, good luck. Good luck. Good luck.
Maggie, you're giving me goosebumps, but I hope everyone else has found this has been already incredible, the knowledge you have shared, because, and I'm not trying to make this a scary episode, although
no, and I don't.
I hope it is, because I want you remember what kind of makes you afraid, right? You tend to remember those, like I shared that original story. I will never forget it because it was terrifying to be like, I am terrified now to even practice. But because of that, I often share with my students some of these near misses that I've experienced in practice, because it does trigger this reaction in your brain where you tend to remember. And I'll share another story that happened to me actually right before I left. I moved to relocate, be closer to family. And literally my last shift at this hospital, and I did open heart there. I was often in these big rooms that had a lot of drugs. You know, the open heart room has a lot of drugs. And we were doing a thoracic case, and we used a large, endotracheal tube. She wasn't the easiest intubation. So we're like, let's give her a hefty dose of Decadron. And in the open heart room, we had those bigger vials of Decadron. They were typically had like a lavender, purplish top. They were, you couldn't see through the vial. It's kind of brown. Well, Levofed has a green top usually. And by the way, I'm telling you this colors because what I'm trying to get at is colors on medications change depending on the manufacturer. So they change all the time. So don't get used to seeing colors. That's a mistake. But that being said, I was with a student and I said, let's go ahead and get Decadron. Let's go ahead and give, her 8 milligrams of Decadron. Anyways, I see out of the corner of my eye, I see her pop this top, which looks like the same vial of the larger vial of Decadron, except it had a green cap. And I'm like, what is that? It was like, what is that? And they had already popped the top, and they looked and they're like, oh, and they got all shooken up because it was Levofed. And I go, whoa. I mean, had they given, and then you typically dilute Levofed, right? Because it comes, in
250.
Yes, correct. Well, had we given 2 cc's of that, thinking it was 8 milligrams of Decadron, that patient would have probably had a stroke. I was so shooken up by it. I mean, I was trembling, and I was like, how did this happen? The pharmacist had put Levofed in the Decadron slot. So this student legit drew it up out of the Pyxis, went to where the Decadron box was, picked out a vial that there was green and purple things mixed in there, and happened to pick the Levofed that was wrongly placed in the wrong slot. I obviously wrote this up. It was a near miss, but it goes to show that we are the last touch point between the patient. So we will catch mistakes that happen up chain. Yes, we didn't make that mistake, but that mistake fell on us to catch. And so I guess I want to share that story because that was very terrifying to know that could have actually happened. And we were only like seconds away from it happening. But similar things for like vasopressin, for example, they can look like Zofran. And if you were to undilute a vial of vasopressin and give it, that's a code dose. So again, a lot of scary things can happen when you're not doing that triple check on reading that vial label. Do never give a medication until you've triple checked. Syringes, like you mentioned, giving Versed instead of Vecuronium, or thinking you're giving Versed and you're giving some other drug in pre-op where it's uncontrolled. You don't have a ventilator or anything nearby. I mean, obviously, luckily that hopefully was a controlled situation that the patient was managed and properly cared for, but it can be very terrifying to be paralyzed and not sedated, right? I mean, so that being said, when you're taking handoff medications, and actually working with students makes me really nervous. And I tend to always hover over when they're drawing up drugs, because if you don't see it happen, you don't know. And if you're taking their word for it, that this is really Zofran and not vasopressin. And
well, let's just pause here, because this is a good place to pause, honestly, because so what would be your accountability? So if that drug would have been given let's just say the patient had a stroke, who would be held accountable? Jenny would be, not the student. Now, the student would have to stand there as well, but if the patient stroked and let's just say they had a poor outcome, you would have to stand in front of and if the family sued, now we're talking about civil litigation, and that could even rise to criminal. And we've seen this more and more, and you're an LIP. So that could cross it over to criminal conduct. One of the reasons why I love students, and but the thing that you have to be extra cautious for is under the rules and regulations of the Board of Nursing, you are the licensed provider. They are not.
What about their RN license though? Because they are still licensed nurses.
And that is a good point. I was going to touch on that. So can they be investigated for their RN? Yes. And can that be disciplined as a student? It sure can. So just say they don't have an RN. They would have to in your process. That it wouldn't, but because they do, yes, they will then go after their RN as well. Even though they're a student in their SRNA program, they still hold an active RN license. So then the both of you would be standing there, to your point, as the student and as a not. But so even if it was an RN and they're not licensed yet, I, as the RN, my aunt's best friend in a home health setting, pediatric home health, she had a student, they allowed a student, she had a student in the home and she got disciplined. And I wasn't even a nurse yet. I was like, what in the crab cakes? Like I had no idea. So I am very hesitant when I'm teaching as well. And just because I know too much. And to your point, I'm not here to scare anyone. I'm not here. I call it nurse love, tough love. And I have my Be Kind shirt on because knowledge is power, and it helps you to leverage your practice as well. When you can say the rules and regulations say this, and it's not on you, it's on the Board of Nursing, who gives me the privilege to practice and say that I am a nurse, says that I have to adhere to this rule and regulation. Therefore, I can't deviate from that. Medical malpractice says, taking on whatever it is, let's just say an unsafe assignment or doing something unsafe. That is the definition of medical malpractice, and knowingly and willingly do that is a deviation from the standard of care and can be considered gross negligence. And I just revamping 2 of my charting courses, one for surgical services and one for just the regular nurse. And those are in both of those courses. I read the definition of malpractice. I read the definition of gross negligence. I tell them what respondent superiors. I tell them, because knowledge is power. Once you know this kind of stuff, and then you're not going to be doing this stuff because you also realize that you could stand in front of 3 courts of law. And I don't think that that's fully appreciated when we get handed our nursing license. And so to your point, I don't want to scare people. I'm very passionate, animated, because those stories that you're talking about, I was working with those nurses, right? Those are the nurses that were drugged through 2 to 3 years of their lives, right? And that it wasn't just the case. It was because someone had a bad outcome, right? And they're having a problem putting that down. Dr. Julie Seamers is the patient safety expert. She's written that book. She reached out to me a couple of weeks ago. She texted me and she said, Maggie, they must have been talking about our mental health. And she said, do you know the number one reasons why nurses attempt suicide? And I apologize, trigger warning. I said, yeah, it's my line of business, Julie. I do. The number one reason why a nurse will take their life is if they get a Board of Nursing complaint. So I know that I'm animated, I'm activated, but it's because I do have a bleeding heart for the nurse. I want to scare you a little bit. It's like, what's that? Scared straight. Remember that? Do you remember this?
Right.
Yes. Yes. So I'm just like a little scared straight. You know what I mean? I'm like, come on down to a little nurse love, tough love. But
yeah, you're trying to help
Yes.
to be proactive and not reactive. This is definitely really valuable. And I also, while we're going to get on the charting, I think for those of you, I think your courses are wonderful. I think it should honestly be a standard.
It's a CE. You do get a CE. You're not going to waste your time. You do get a CE. I did do the work.
Really affordable. I don't remember. You can share the prices.
Yeah, and I'll give all your viewers a discount. I mean, it's $50. It's nothing crazy. And there's a 20-page handout that comes with it, because I want you to pay attention to what I'm saying. And so those definitions, anything that I put in there, it's in the handout, because it's far more valuable for you to listen to what I'm saying. And then you can have that handout with clickable links. You know what I mean? Because again, with examples, to your point, because that's what you need to see. You need to see the real examples woven in there. Yeah.
But to your point, we need to know how to document to protect ourselves. And that was going to be the next thing. And I was going to share something else that another CRNA shared with me over the years when I was in training about everything you possibly can needs to be documented. Attending notified, surgeon notified, all communication. And then one thing that oftentimes I always tell students who I'm training an Epic. So like an Epic, you pick standard templates, right? Yes. So maybe it's a general LMA, and then it populates all these standard drugs. Unfortunately, if you don't remove those drugs and it looks like there's morphine and Dilaudid on there that never got charted on, they're going to be like, well, did you or did you not give this drug? Why is it on your chart? And I always tell someone, you got to remove it. Like, if you don't give it, remove it, get it off your chart. And I was lazy like that in the beginning too, where I was like, whatever, I didn't give it. It's just going to sit there. No, remove it. So what are your thoughts around stuff like that?
Well, I think you're spot on, because then you're going to be asked about that. And let me just tell you, okay, you didn't do anything wrong. It was one incident, something happens. You're already uncomfortable in civil and criminal litigation or in the board of nursing, right? You're already uncomfortable. And now you're being questioned on something that, should I have removed it? Shouldn't I have, you know what I mean? And now they're going to trick you up on something that was really basic. They keep tricking you up. All they're going to show is a trend in your behavior that's going to lead to gross negligence.
Right. And then on top of that, are you going to really remember whether you gave Dilaudid or morphine a year ago? When this comes up, you're like, yeah, I have it on my chart, but I didn't give it. They're like, how do you know that? And like, I wouldn't know that. And so like, that's just the thing that it leaves these deficiencies that shows, like you said, almost like being sloppy, where it allows them to nitpick you, even though it's freaking an epic thing. I mean, they just populate all this stuff for you, which probably happens all the time, but it's just allows them to nitpick, and they will nitpick because they want to make you look bad so they win their case. That's the whole point.
Every single person they will nitpick, and you can be on the stand for 6 hours a day for as many days as they want you to. Oh yeah. And just so you know, if you're on the stand, you already know there was a wolf nurse that produced a report that the attorney already has all the words. There would not be a legal case if there wasn't an expert report with the same or similar modality who wrote up all the words that you deviated from the standard of care. So they have leverage against you. So they already have someone who's going to get on the stand. It will be like you or I that get on the stand to say she grossly deviated, and but this is not personal, right? Yeah. It's just, these are the deviation, because now it's your family. It's your family that died, right? You don't think that you deserve an unbiased expert who's going to give their opinion whether you deviated from the standard of care, right? There's two sides to that coin, because some people are like, well, you've been an expert. I don't do civil cases anymore, but I don't think there's anything wrong with you being a civil expert. We all need, you know what I mean? There's nothing wrong with that. So no, get it off your chart, get it off the other thing that I've seen, more so with the anesthesiologist, because I've done phase 1 and phase 2, is that you don't get to sign off if you're not here. That's a very poor practice. And the doctor can say that all they want. I'm still coming to you as the phase 2 nurse, or the phase 1. I'm saying, I know you already signed off, but this is what's happening. I'm giving the rundown. I'm moving them to phase 2, or they're going home. Are you okay? Because anesthesia is signing them out from that department. The surgeon doesn't care. What's all the risks involved? It's the anesthesia. It's all the anesthesia. And then let's back that up. If you think that you're at a surgery center and this person is not appropriate for an ASC, you better say no. You better not introduce a drug. You better say no. I've been in pre-op, and I was just a pre-op nurse. We had a patient came in who was already on oxygen, going to be a full shoulder sister. And I was like, so I just brought him back. Never disrespectful. Put him in the room. Didn't even have to change their clothes. So I go over to anesthesia. I was like, hey, I got a gift for you. I was like, we got a winner. And I said, but that's not my lane. I said, so we're on like 3 liters of oxygen. This is the shoulder you're going to do the block on. And I said, no. And you see how where PAT missed that? This person was not appropriate to be, or even better one. I'm pre-oping someone for a GI case. And this is why you need to respect the pre-op nurses as well. Anesthesia. And again, I'm giving a little gift because I'm on the other side. They sometimes don't respect us, but I'm also protecting you. Right. So patient came in, was not English speaking, Spanish speaking, was saying something about cardiac stuff. We're having an upper and lower, and it's endo. He had a stent placed, cardiac, 2 weeks ago. And we're having I was like, no, we're not. So again, I went to anesthesia. I was like, hey, I got a real gift for you. So do you care? So we're post-op day 14 from a RCA stent. Does that mean anything to you for this elective upper? I don't know, but I'll let you go in and take care of this. But you see what I mean? You have to say no. And it's sometimes about money, but you have to say no.
Well, I hope you've enjoyed listening, future CRNA, and I hope you have found so far the knowledge we have shared really impactful and valuable. This is the end of part 1, but be sure to tune in for the next part 2. Be sure to save CSB podcast so you do not miss when we drop the next episode. And be sure to check out Maggie's website, advocatesfornurses.com. Maggie Ortiz is phenomenal. She's so valuable. It's definitely somebody you want to know and have in your pocket. Hopefully that nothing will arise, but I think this is someone you want to make sure you're connecting with, you're following, Maggie on LinkedIn, you're going to her website and seeing the other value she can offer you. It's always important to know the next steps should arise. Her courses, again, are very affordable, and I will be sharing the discount link in the show notes below. So again, this is the end of part 1. Stay tuned for part 2.
Thank you for tuning in. Be sure to head over to CRNAschoolprepacademy.com to gather free resources to help you on your CRNA journey. Stay strong. We're rooting for you, future CRNA.